Welcome back to the ProPA podcast. I'm your host, Prof. G, and this is another episode of our MSK101 Clinical Medicine Brief series, where we focus on high-yield musculoskeletal topics straight from the PANCE blueprint. Whether you're studying for a big exam or refreshing your clinical skills, we've got you covered. In today's episode, we'll break down osteomyelitis, including common pathogens, routes of infection, diagnosis, and treatment options. Let's dive in. Did you know the most common pathogen causing osteomyelitis is Staphylococcus aureus, and that hematogenous spread is the most common route in children? Let's look at the Kinderpatho. What is osteomyelitis? Well, it's an infection of the bone, and it's usually caused by bacterial invasion. The infection can reach the bone through hematogenous spread, which we mentioned is especially common in children, typically affecting the long bones. It can happen via contiguous spread from adjacent tissues or from trauma, or direct inoculation following things like open fractures, surgery, or puncture wounds. Infection leads to inflammation, bone destruction, and necrosis. Sequestra, or dead bone, and involucrum, which is new bone formation around the infection, may develop in chronic cases. Now let's look at the clinical presentation. So symptoms are going to vary based on the age and the mode of infection, but some of the more common symptoms we'll see are fever and malaise, and we see this more often in children. We can also get localized bone pain, swelling, warmth, and redness over the affected area, and decreased range of motion if it's near a joint. Don't forget, in vertebral osteomyelitis, patients may complain of back pain without systemic symptoms. All right, so how do we work up these patients? Well, we start with laboratory studies, including an elevated white blood cell count, an ESR, and a CRP, which are nonspecific markers of inflammation. As far as imaging is concerned, we want to x ray the area that we're concerned about, but it may not show changes for 10 to 14 days. An MRI is the most sensitive early imaging study we can order, and a bone biopsy and culture is considered the gold standard for identifying the organism. Blood cultures may also help us identify the causative agent. All right, so how do we treat these patients? Well, empiric antibiotics, which are tailored after culture results, it's going to be the mainstay of treatment. These types often include vancomycin plus ceftriaxone or other agents based on the local resistance patterns. The duration, we're going to typically treat these types of infections for 4 to 6 weeks, and we're going to use IV antibiotics. Sometimes we even have to do surgical debridement, especially if there's necrosis, abscess, or failure to respond to antibiotics. Some special considerations. Sickle cell patients, they often get infected with Salmonella, and IV drug users consider Pseudomonas. All right, so now let's look at the book med versus the street med. So, book med, you're going to see a febrile child with localized limb pain, maybe an elevated ESR or CRP, and an MRI that shows bone marrow edema. Street med, on the other hand, you're going to see a diabetic patient with chronic foot ulcer that just won't heal despite antibiotics, and an x ray is going to show some cortical irregularities, and an MRI lights up like a Christmas tree. All right, so let's wrap up with some clinical pearls. So, Staph aureus is going to be our number one cause in most populations. We always want to consider Salmonella in sickle cell disease. An MRI is the imaging study of choice. A bone biopsy is the diagnostic gold standard. And early treatment reduces the risk of chronic osteomyelitis or limb loss. All right, now let's move on to some PANCE style practice questions. Question 1. A 7-year-old boy presents with fever and refusal to bear weight on his left leg. Labs show an elevated ESR and CRP. X-ray is unremarkable, and an MRI shows marrow edema in the femur. What's the next best step? Is it A, oral amoxicillin, B, immediate surgical debridement, C, intravenous antibiotics, or D, bone biopsy and wait for the results before treatment? I'll give you a few seconds. If you said C, intravenous antibiotics, you are correct. So early empiric IV antibiotics are going to be appropriate while waiting for culture results. Question 2. A 35-year-old man with diabetes presents with a chronic foot ulcer and a new onset of localized pain and warmth. MRI shows signs of osteomyelitis. What is the most likely organism? Is it A. Salmonella, B. Staph aureus, C. Pseudomonas, or D. Streptococcus pyogenes? I'll give you a few seconds. So this one was a tricky one. The correct answer is actually B, Staphylococcus aureus. And staph is going to be our most common cause overall. Pseudomonas is also possible, but less common unless there's a puncture wound through the sole of a shoe or IV drug use. All right, so some final thoughts. Osteomyelitis is a high yield, frequently tested topic. We need to know the risk factors, common organisms, and imaging modalities, and we need to know how to approach treatment. Keep an eye out for those red flags like chronic non healing wounds or back pain in high risk patients. Did this episode help you? Be sure to follow the ProPA podcast so you never miss a high yield review, and check out our YouTube channel, Professor GPAC, for more tips and clinical content. And remember, this is the ProPA podcast, where future pros in medicine are made. See you in the next episode.